Today we're going to primarily speak about this three-pronged approach that I've developed, but along the way we're going to add in some prostate cancer pearls of wisdom. And a pearl in medicine is a factoid, a fact that may or may not be logically construed. In other words, it's something that is true, but there may not be any good logical reason for it. It's an observation, and it holds true. I hope you all brought paper and pencil, because you're going to have a test here. And the first question is, for men on chemotherapy and or hormone blockade, alcohol, even in moderation, should be avoided most of the time. And I see a show of hands. True? Anyone say true? A couple of trues, a couple of trues. Anyone say false? More say false, and 80% said nothing. Okay? So we'll go on to the next question. Sexual relations by raising testosterone levels are potentially harmful and could make some prostate cancers grow, especially metastases. Show of hands for false or true. Let's do false first. Not quite half. True? Only one. Again, a ton of abstainers. And I think the last question, men with active prostate cancer need to use condoms, or their sex partner could be exposed to potentially harmful cancer cells which could damage their partner's immune system or possibly even cause some type of cancer in their partner. True or false? True? False. You did well on that one. They all were false. All of them are false. So you can have sex, you can have alcohol, kind of almost as much as you like. This one, though, back in the early 90s, I was a Casodex investigator. And a study was done comparing Casodex monotherapy, 50 milligrams, one a day, to Zoladex. And AstraZeneca wanted to see if patients could get the same response with Casodex as Zoladex, but have a better quality of life because they would retain, a higher percentage would retain sexual activity. So one of the oncologists on over the hill called and said, "Bob, I heard you're an investigator. I want to refer someone to you." And he did. The guy comes out. He was about 78 years old. I think his name was Herb. And he wanted to enter the study. So he did. And it was double-blinded. So we didn't know if he was on Casodex or Zoladex. Well, about 6-8 weeks after being started on treatment, his wife happened to come with. She says, "Doctor, I would like to talk to you in private." I said, "Okay. What is your concern?" "Well, you think maybe I could get some type of a cancer from if we have like the sex?" I said, "No, I really don't think that's possible. I'm quite sure." She said, "Well, please don't tell him because I never really cared for the sex anyways." So I go to the patient. I say, "You know, Herb, the only reason to be on this study is if you're trying to maintain sexual activity. And, you know, I have a feeling that may not be all that possible, you know, with your wife and everything." He said, "It's okay. I go to Vegas twice a month." It's a true story. And I guess what happens in Vegas stays in Vegas. Okay. So, who knows about Abiraterone? Really? So abiraterone acetate, it's a potent and irreversible inhibitor of the enzyme CYP17, which is a major contributor to androgen synthesis. It's required for synthesis of testosterone in the testes, adrenals, and in prostate tissue. Who knew that? Come on, I don't think so. I made it up. Oh, no, I know it's true. Ketoconazole also inhibits CYP17, but is many times weaker than abiraterone. So, trying to stay ahead of the game, here's some information that will be presented 2 weeks from tomorrow. Can't get more current than that. When I was at Harvard, we called this, you know, one-upsmanship, gamemanship. This was before there was online publications, and you know, some guy would say, well, it will be reported in the Journal of Trivia and Irrelevant Information in August 2010, and then he'd make some, anyway. So there are 4 consecutive abstracts that deal with abiraterone. And one of them, 56 patients, had metastatic, we used to call hormone refractory prostate cancer, but the correct terminology now is castrate-resistant prostate cancer. And that simply by definition means that the PSA goes up while you're on hormone blockade with a testosterone level under 50. And these patients could have up to 2 prior chemotherapy regimens, including Taxotere. Abiraterone, 1,000 milligrams per day was prescribed, plus prednisone, 5 milligrams twice a day. Average age, 69, baseline PSA, 151. Prior hormone therapies averaged 4, chemotherapies 1, which had to be Taxotere. And 24 patients had prior ketoconazole, 32 never had ketoconazole. Now remember, ketoconazole is competing for that CYP17, just like abiraterone. All righty? And for those of you who know the current protocol that Cougar Pharmaceutical is conducting, prior treatment with ketoconazole is an exclusion factor. You can't go on their studies. Well, let's see if there's a reason for it. Looking at any point in time maximal PSA decline of greater than or equal to 30%, 50%, or 90%. If you had prior ketoconazole, 42% had PSA declines of 30%. If you never had it, 63%. PSA decline of over 50% was seen in 1/3 of prior ketoconazoles, 53% ketoconazole naive. And over 90%, only 4% if they had prior ketoconazole. 31% had that nice decline if they did not. The progression-free survival, how long before your PSA started to go up after starting abiraterone? If you had prior ketoconazole, 99 days. If you had your ketoconazole naive, 198 days. But now think about this. In this study, patients had to have progressed on Taxotere and an average of 4 different hormone blockade agents. And in spite of that, they were able to be treated with a pill, abiraterone, for more than 6 months. That's remarkable. And the pill's side effects are very minimal. So this medication is going to be a grand slam home run, in my opinion. Now, can someone tell me what the average testosterone level is for men who are on aggressive hormone blockade? Well, first of all, what's castrate? Less than 50, right? So an average testosterone level, well, we like to have it be less than 20. That's as low as the assays measure it. But when you go on Abiraterone, the testosterone all drop to 0. So Abiraterone is hormone blockade. Nothing fancy about it. It's just more effective. And it tells us that what we called hormone refractory prostate cancer, now you're thinking refractory means nothing that I can do in the way of hormone blockade is going to help that patient. It's hormone refractory. But in fact, it isn't hormone refractory. It's castration resistant because what we've had up till now did not lower testosterone to unmeasurable. And there's a second medication by Medivation and study, much smaller study that also affects testosterone levels this much. But Abiraterone is far out ahead of the pack because they've done studies longer. Now, how about if you previously had Taxotere and you've got metastatic castrate-resistant prostate cancer, total maximum PSA decline at any time on study, 69%, 51, and 15%. These men were 67, PSA 403, 3 prior hormone blockade agents. They had to have had prior chemotherapy, including Taxotere, and 6 of them even snuck through on ketoconazole. Now, here's this remarkable figure again. Taxotere stops working. And all these other hormone blocking agents didn't work any longer. But for more than 5 months, Abiraterone controlled their disease. Now, in the future, we need to figure out what can we add to Abiraterone to improve its responsiveness. Should we be adding Taxotere to it because it's not hormone blockade? Should we be adding anti-angiogenic cocktail? What should we be doing? I don't have that answer. Now, here's a group of men, metastatic, castrate-resistant, no prior Taxotere and no prior ketoconazole, if they were telling the truth. Again, 1,000 milligrams a day, prednisone, 27 patients, average age 71, PSA 25, prior hormone blockades, agents 2. Maximum PSA decline, 82%, 78% had over a 50% decline, and 26% over 90% decline. Now, in this group, these are favorable guys, no Taxotere, no chemotherapy, and no ketoconazole. So how long was their disease controlled with Abiraterone? Median time to PSA progression hasn't been reached yet. Isn't that nice? It also lets you know how important pre-treatment prognostic factors are. Because if you choose a group of men that you're going to treat with medication A, and they all progressed on ketoconazole, and they all progressed on Taxotere, and they're bedridden with an average 30-pound weight loss, and they're on narcotics, no matter what you give them, unless the Lord's administering it, you're not going to get a real high response rate. So this is in the best case scenario, but it's legitimate. I mean, these are real patients that we see. And this abstract talks about some very interesting and emerging useful information on CTC and additional methodologies. Does anyone know what CTC is? So most of you apparently do not. So I'm not going to tell you. CTC is circulating tumor cells. And I think we have some slide on it a little later on. Is this a medication you're familiar with? Denosumab? It's made, right? I'm sorry? Amgen. And We know that bone mets can occur in up to 75% of patients with advanced prostate or breast cancer and more than 95% of patients with multiple myeloma, which is a form of bone cancer. And in the April 1st, 2009 Journal of Clinical Oncology, there is an article and an editorial that discusses mostly patients with breast and prostate cancer who are being treated with Zometa, metastatic bone disease. And we know that cancers cause resorption of bone, dissolving away of bone. And what I said here is picture prostate cancer cells doing something to the bone environment that causes imaginary termites to start attacking bones. Now, if any of you have ever had a wooden bowl or a little statue in the house, and it was infested with termites, what you find is when you look at it the next morning, there's little wood shavings, either on it or right around it. I remember when I was a resident 100 years ago, we took a Caribbean cruise that I think the two of us together, $500, we were able to see Jacques Cousteau working out of our port window. We were really on a low level. But anyway, we bought these salad bowls for like $20. We got 6 bowls and a big bowl, but noticed little things of wood. I mean, it almost like pencil sharpener thing, but even thinner. So fortunately, that wasn't new for the ship people, and they just take those items and they put it in the freezer on the ship. And then they give it to you at the end of the cruise, and all the little termites are dead. So unfortunately, we can't do that with bones. But in reality, what do the cancer cells do is they stimulate a cell called an osteoclast. Now, in bone, there are osteoblasts, which build up bones. Growing teenagers build bones. And osteoclasts, which dissolve bone. But in normal people, you have that process going on, and it's in check. Like someone breaks a bone, you have to redesign it, and you need osteoblasts and osteoclasts. And how can you measure if a person has excessive bone resorption, which would suggest that cancer cells are causing bone to dissolve? Well, you can measure urinary N-telopeptides. Unfortunately, a lot of insurance companies still won't pay us to do that. Now, if you have a patient with metastatic breast cancer or prostate, and they're being treated with Zometa, Zometa will lower their urinary N-telopeptide levels. But around 20% of patients on IV bisphosphonate, specifically Zometa, will still have elevated N-telopeptide levels. So they took for this study those patients, in other words, on bisphosphonate but still high urinary N-telopeptides, and they then randomized them, prospectively, blind, to receive continued Zometa or to switch to denosumab. And the reason this is so important is that patients with metastatic cancer and persistent elevations in NTX have been found to have reduced survival or increased adverse outcomes. So this was a phase 2 randomized study, 111 patients. And those who remained on Zometa, 29% had their urinary levels go down to the correct range that you would want. So it showed that they just needed additional Zometa to reach that level. But for the patients that were randomized to denosumab, the result was 71%. 29% versus 71%. And how is denosumab administered? Is it IV like Zometa? Nope, subcutaneously, once every 4 weeks. And so far, no patients have developed osteonecrosis of the jaw. Now, it's actually May 31st that it's going to happen. I was so excited. Anyway, so they're going to have a poster presentation of denosumab where they're describing a study for men with prostate cancer without known metastases who are going on androgen deprivation therapy, and they're being treated with denosumab once every 6 months. And the dose is only 60 milligrams, whereas the every 4-week dose in the other study was 120 milligrams. And what they found is the vertebral fracture rate was reduced by 62% compared to placebo, just from 2 doses of denosumab a year. So in my first time I used this many varies, very, very, very strong opinion. This drug will probably get FDA approval sometime this year. It will be a blockbuster, and it will soon be the standard of care for treating patients with bone mets, and a standard treatment for treating osteoporosis, including that induced by hormone blockade.
What's it cost?
Don't know.
Priceless?
Use your Visa, your MasterCard. Well, you know, for the insurance company though, they're not going to be an infusion charge. You know, so that part is going to be less. But some people believe this will be one of the top 1, 2, or 3 selling drugs in the world real quick. Okay, back to that CTC test that it's pretty new information. So the CTC test, it's a blood test, and it's FDA approved already to follow patients with either metastatic breast cancer, metastatic colon cancer, or metastatic prostate cancer. Fred or Joe, have you seen our CTC machine in the hallway there? No?
But I know about it.
You have, Fred?
I've seen it.
Yeah, I mean,
Guard on it, it was so expensive.
yeah, it's true. I just chained one of my kids to it, actually. But in prostate cancer, what this test does is it measures circulating cancer cells that are found in a total of 1.5 teaspoons of blood, 7.5 mLs. And they find that if you have fewer than 5 cells, that's a much better prognosis. And they find that if you start with 10 or 20 or 100 or 1,000 or whatever number, and within 1 month your CTCs drop to less than 5, your survival is markedly improved compared to someone whose CTCs don't drop. And if your CTCs go up on therapy, even though your PSA may be stable or declining, even though you don't have any symptoms of pain, if the test is accurate, maybe repeat it again, the test is accurate, the CTC is a better prognostic value and more informative than any other test. So it can guide your therapy sooner than patient-reported symptoms, sooner and more reliably than PSA changes, because for those men who've required all kinds of extra treatments, all kinds of extra therapies at different times. You've seen PSAs blip for no reason and then go back to a certain level. So a lot of false positive, false negatives. Think of somebody who's on chemotherapy and the CTC test shows that chemotherapy, this regimen, is not very effective. So instead of sticking with it, the doctor can change sooner. Okay, getting into the heart of our lecture today, we're going to be talking about this three-pronged approach that I've developed for treating advanced, metastatic, recurrent, aggressive, high risk, any of those categories, castrate-resistant prostate cancer. Now, if prostate cancer has already spread, the most difficult concept for a patient to grasp, to understand, to accept is it's not curable. All right? How many people with diabetes are cured? How many people with hypertension are cured? But you can convert those diseases into chronic illnesses that you live with and die with, not from. Well, that's my job with prostate cancer, to convert it to a chronic illness, to get the prostate cancer cells to hibernate, become dormant. But you will require some type of therapy for the rest of your life, depending on whether it's metastatic versus just high-risk presentation and that sort of thing. Patients also are under the impression, when they hear they have metastatic cancer in general, well, I'm a goner. I'm not going to be here for more than another Christmas or two. Everyone knows that metastatic, just get all your affairs in order. Almost without exception, however, our patients, assuming they allow treatment and actually take their medicines, are going to do or are doing much, much, much better. And Nathan Roundy is putting together a follow-up on some of our patient categories, and we'll ask him to talk a little later on about what he's been looking at. He's the volunteer that put together our database for triple hormone blockade when we presented our results in 2005. And when he talked about wanting to help, I said that it would really be nice because I know that it sounds terrible, self-serving, braggartly, but literally compassionate oncology has the best results of any facility in the world for managing these types of patients. And in the past year, I feel certain that Nathan will more than substantiate that, because he's actually put together some analysis comparing it to leading centers, and we won. Now, what is this alleged three-pronged approach? Well, let's take somebody who previously was treated with hormone blockade. Let's say they had a radical or radiation, and then they went on one cycle of hormone blockade, any kind, monotherapy, combined, triple. And by the way, I don't recommend 13 months triple hormone blockade for alone for patients who have progressed after prior local therapy like radical or radiation or seeds or cryotherapy, or prior hormone blockade. Because what I've found since at least 2001 is that if you take that kind of a patient, their PSAs will become unmeasurable while they're on their 13-month triple blockade. But 6 to 24 months later, their PSAs, virtually all of them, their PSAs begin to rise. So in 2001, those patients became high risk, and I changed how I was treating them. Now, a three-pronged approach means we use alternate hormone blockade. If they've previously had hormone blockade, one of the nice things is they're only treated for 9 months now, not 13. But I never give an anti-androgen a second time. What are the anti-androgens? Casodex, flutamide, nilutamide. And I've got some slides on it. Then patients are also treated with 15 doses of weekly low-dose Taxotere MCT carboplatinum chemotherapy, 3 weeks on, 1 week off. What does that mean? Well, let's pretend that someone was coming to see us and they're starting treatment this coming Monday, and they live in Chicago. They get a dose of chemotherapy Monday in our office. Then each of the next 2 Mondays, they're treated in Chicago. That's 3 weeks on. Then the 4th Monday, they're off, no treatment. So only 3 days every 28 days are they getting an IV. Now, when a layperson pictures somebody on chemotherapy, the typical picture is they imagine or they see somebody who looks and feels sick and terrible. They throw up, they lose their hair, and then they die. And patients have this horrendous fear that that's going to happen to them no matter what kind of chemotherapy they're treated with, because that's the only scenario that they've seen on TV and in movies and talking to relatives. Has anyone talked to patients that had chemotherapy and had a pleasant experience, or at least absence of any bad side effects? Well, we have a list of about 80 patient volunteers, men who have volunteered to discuss their experiences being treated with different protocols that I've created. And what I find is prospective patients love this idea that they can call 80 different guys or more, or email, or whatever they like, some in Germany, you know, some in the LA area, and talk heart to heart. Men on this protocol don't ever throw up. Fewer than 1 in 7 has any significant temporary hair loss. Always grows back. Unlike standard chemotherapy, this doesn't lower your white count. It doesn't increase your risk for infections. Men who are working full-time are able to continue to work full-time. Fred has been with me almost 16 years now. Has been in the infusion room a lot of times over those years. Have you ever seen anybody throw up?
No.
Which is remarkable, because if any of you are going to an oncologist and are ever in the infusion room, you know what kind of patients you will see at different times. Somebody without hair, somebody throwing up, somebody who can't eat. It's so nice not having that, because, you know, I trained as a hematologist oncologist a billion years ago at Harvard, and it just is part of the territory. You're going to make people sick. And it's like, we're sorry, we're doing the best we can, but this medicine can prolong your life, this, that, and the other thing, although in those days, not that many of them did. In addition to the hormone blockade and TEC chemotherapy, I also have developed an anti-angiogenic cocktail. These are medicines that turn off the blood supply to cancer cells. And this came directly out of my being able to have the privilege of working with Dr. Judah Folkman when I was doing my fellowship. He was at Harvard's Boston Children's Hospital at the time. Dr. Folkman was a pediatric oncologic surgeon. And he also died within the last 12 months. And I remember being with him and him telling me, Bob, the key to controlling cancer is turning off the blood supply. Now, I'm not at all good with abstract concepts. I'm a pure logic kind of a guy. Like black comedies, I don't get. So I'm thinking he's going to go into this patient and put sutures around arteries and veins going to their cancer. But of course, that had nothing to do with it. He was referring to substances that were not yet described, but that he knew were there, that promoted new blood vessel formation or turned it off. But it so happened at that time, in the 70s, that there was a type of cancer that spread to the liver where you actually did tie off the portal vein. And the normal liver could regenerate, and turning off the blood supply, the rest of it would cause remission for certain rare tumors. So that's what I thought was going to happen. Anyway, the most important part of the anti-angiogenic cocktail is leukine, also as GM-CSF, it's known as that, and alternating Revlimid thalidomide. Thalidomide is the drug that caused birth defects, you know, the short flapper limbs. Never FDA approved in the United States until 1998. It's approved as an over-the-counter product in Europe and Canada. And if a woman took a single thalidomide capsule between something like 16 and 40 days after her last period, and she had conceived, she could have a thalidomide baby. Then some other anti-angiogenic quote-unquote helpers, Proscar or Avodart, or low molecular weight heparin, which is a blood thinner, Celebrex, only 200 milligrams once a day with food, possibly some Zometa, and more recently, a statin like Crestor. Now, it's all nice and theoretical talking about anti-angiogenic cocktail, but does it really work? Well, here's a patient that December 98, he was 62 years old. He had a PSA of 33, locally advanced disease, T3A. Gleason 3+4 total 7, as read at Johns Hopkins. 4 out of 8 cores were positive for cancer, 100% of each of those cores. He had 2 months of combined hormone blockade, then switched to triple blockade. As an engineer, he had lived in the US for a number of years. After learning about me, a number of years later, he asked for permission to translate my papers into German and post them on the web. And additionally, he started a triple hormone blockade group in Germany. And many years later, I went over there and lectured at 4 different cities. If anyone's been in my office or looked at my website and sees all of these pins in our map of where our patients come from, there's more than 150 patients that I've seen from Germany alone. So this is a very busy slide, and you don't have to worry, it's the next slide that's more important. But this goes back to November 2000, shows all of his PSAs. This is a 12.6, this is a 15, and I had started him on thalidomide back, I think, in 98 or 99. Then here's when he started on leukine. And isn't this interesting? So I mentioned that most of the benefit comes from leukine and thalidomide Revlimid. He's an engineer, and you can tell engineers because they usually come in to see you with PSAs plotted on a log scale. I think Joe had done that and compared it to phases of the moon and a number of other very relevant factors. But notice that when he started leukine, although he continues to have ups and downs, his PSA in April '09 is less than 1, which is the lowest it has been since he was on hormone blockade more than 10 years ago. 1 cycle, triple blockade, never had local therapy. And I think that's wonderful. I mean, you know, for all the years that I've been, you know, called an idiot and criticized, and everyone has heard that my treatment doesn't work. There's no evidence it does this, that, and the other thing. Well, he's obvious proof that it does work. He's one of the 80 or so volunteers. And it tells you that you don't have to have aggressive local therapy in order to survive. And in fact, what would his chances for survival have been if he had a radical prostatectomy with a PSA 33, Gleason 7, 50% of his cores showing cancer, and 100% of each of them? There's his PSA August '08, September '08, October '08, November, February '09, March, April 20. I thought it was 1. I thought it was actually under 1, but at 1.32. I think his most recent one is actually under 1. I mean, not that it matters. And we see this a lot too. The guys will be on it for years, and then their PSAs decide to take another major decline. And if you ask, do I know why that occurs? The answer is yes. It's what I refer to later as the GOK syndrome, G-O-K, which I know you all know that stands for God only knows. So that's the explanation that explains how this occurs. Well, now let's look at this three-pronged approach. This is a patient, Leroy, who had worked on the oil platforms in the Gulf. Kind of a tough guy, because at one time he had a bad toothache. They called for a helicopter to come out to take him into a dentist. Instead, he grabbed the pliers and pulled his own tooth. They don't make guys like that anymore. His grandson was a classmate of my son's for at Harvard MBA. And the grandson called, said, you know, 81-year-old grandfather, has 30-pound weight loss, severe, horrible, generalized bone pain, bedridden. They went to do a bone scan, had to be hospitalized in Louisiana because he couldn't tolerate the pain just for being on the bone scan table, and required shots of Demerol. So his PSA was 6,272. 30-pound weight loss, bedridden on narcotics. It turns out morphine. His PAP, PAP, prostatic acid phosphatase, and when the PAP is elevated, it's a much, much, much worse prognosis, much, much more aggressive. Gleason 9. So I said, well, he needs to come out here so I can see him. And the family said, there's no way in the world we can get him out there. He's, you know, in too much pain, too sick. So I started him on Decadron pills. Great pain medicine for bone mets. had to come out in a wheelchair, special handling on the plane. And the first day I saw him was in the exam room, and I started him on a three-pronged approach. And he'd been bedridden for about 6 weeks. At the end of the infusion, I said, Leroy, your wheelchair is just outside the door to this exam room. You're going to have to walk to it. He did, took off his morphine patch, never needed pain medicines after that. For his 85th birthday, he went out to dinner with his family. When he came to see us for the next visit, he showed us his pictures for his birthday from Hooters. Now, I had actually never seen a Hooters restaurant. I mean, obviously I know what Hooters stand for. It's people studying owls, I think. But Leroy just had a grand old time. And, you know, just such a natural high for my staff, for myself, that you get a guy who's bedridden with all this pain, the PSA 6200, and a number of years later, he goes to Hooters for his birthday. He actually had high-dose testosterone, went on a second cycle of hormone blockade, started an anti-angiogenic cocktail, PSA 0.176, December 03, 4 years later. In August 04, the last office visit with me, we recommended that he stop cycle 2 testosterone, and in January 05, he died of complications of Alzheimer's, but he was 88 then. This is a patient, 55 years old, African American. PSA was not that high, Gleason 7, 6 out of 6 cores. Endorectal MRI showed extracapsular extension. He was treated at Memorial Sloan Kettering, radical prostatectomy, had a ton of disease. They couldn't get it all out. 2 positive nodes, Gleason 8. Seminal vesicles involved, margins involved, extracapsular extension, and notice how much blood he lost. Now, how much blood does a normal guy have? How many pints? 10. That's 5,000 cc's. He lost half of his blood. And the urologist who did the surgery is one of the best known urologists in the country. And he told him, brought him in and said, John, unfortunately, you're not going to do well. You need to get your affairs in order. And sure enough, his PSA began to rise within 9 months of surgery. And from December 03 to June 04, it more than quadrupled. So that would be in 6 months. It doubled twice, PSA doubling time less than 3 months. It actually was 2 months because PSA rose to 1.98 in August. And I treated him with three-pronged approach. He, in August 05, discontinued hormone blockade, continued on anti-angiogenic cocktail, and then does anybody here know that I sometimes have treated men with high-dose testosterone after they've been treated for prostate cancer successfully?
Yes.
There's one guy. Yes. How many did not know that? Okay. Well, everyone, I mean, you guys have all been told if you've had prostate cancer, you must never take testosterone because it's like pouring gasoline on a fire, right? In September 05, PSA was over 4,000. I mean, testosterone. PSA less than 0.01. In October 05, 4,000 again, less than 0.01. In February 06, 2,406, less than 0.01. When we spoke to him, John, since you started high-dose testosterone, is anything worse than before? He said, no. is anything better? And I said it as, what if anything is better? Because you don't want to prod him. He said, well, I have a dramatic improvement in mental acuity. He was a CT technician in New York and also was going to seminary school. Said he has increased energy, marked improvement in libido, improved overall sense of well-being, morning erections, having orgasms for the first time since surgery. That was 3 years before. I remember treating a patient who was in his 80s. And when I put him on high-dose testosterone, he wrote out on a yellow legal pad sized paper, praising us and blessing us, and he said that it's the, he had had radiation. First time that he was able to have an erection and orgasm in more than 8 years. So he stated, John, that he felt absolutely wonderful. He'd regained his lost confidence in life and loved how he felt. Then in 2008, testosterone, 5,100. What's the normal testosterone?
Less than 1,000.
I'm sorry?
Less than 1,000.
Okay, how far down?
I think down about 400.
300, 280? Yeah. Usually it's considered 300 to 800 or so. So 5,000, 1,900, 3,100, 2,100. In December 08, 0.12, but in May 09, 6 months later, 0.12, with a testosterone of 4,000. This is a gentleman that, strap yourselves in. In November 03, 61, PSA 3,346. He had about a 30-pound weight loss. He was urinating every 10 minutes or so. He was a patient at Kaiser. He was biopsied, Gleason score 8, reviewed at Johns Hopkins, multiple bone mets. Now, his urologist gave him an appointment to return in 16 weeks. Gave him a 12-week shot of Lupron and referred him to hospice service. The hospice person told him and his wife that they need to accept this fate and get their affairs in order, that unfortunately this is how things go, and hopefully he won't be in too much pain. He had mets in all these places to begin with. 22-pound weight loss. So I treated him with my three-pronged approach. By September 04, PSA 0.003. Not bad, over 3,300. In January 05, we got to stop his hormone blockade, his 13 months of hormone blockade. Continued him on anti-angiogenic cocktail and added in some testosterone. January 05. So here it is, more than a year and a half later, PSA 0.5 with the testosterone 2,200. But remember, he still has his prostate gland. Testosterone is going to stimulate your normal prostate gland cells to make some PSA. So this is certainly not abnormal, especially with that healthy testosterone. And 7 months later, 0.6, testosterone over 2,000. He returned to Kaiser, I have no idea why, and he didn't like having to pay out of pocket for certain lab tests, so he just felt in August 08 that he was going to stop testosterone. What would happen to his PSA then? Wonder. Well, there's his PSA, unmeasurable, March 09. And if you look at Dr. Duke Bond study in August 08, this lesion was 14 by 14. In April 09, it dropped to 9 by 7. 16 by 12 dropped to 10 by 8. The increased vascular supply no longer present. 17 by 18 dropped to 15 by 12. Dr. Bond was astounded. But this is what we're seeing. As of May 09, it's been more than 5.5 years since he presented PSA 3346 and was referred to hospice. He continues to work full-time, remains totally asymptomatic. And I got nothing more to say if this doesn't, it's like, who's going to top this? I mean, this is Trumpsmanship. How about this gentleman is a PhD. In March of 99 was 49, 17 out of 18 cores, Gleason 4+3, 80% to 100% involvement. He was seen up at Fred Hutchinson, had a radical by Dr. Paul Lang, who, by the way, had invited me to speak at Fred Hutchinson this past November on high-dose testosterone to the urology department there. And it was really nice. He was very impressed, and it was wonderful. So he goes to surgery, 6 positive lymph nodes. Gleason 4+4 going in, but now it's a 4+5. Bilateral seminal vesicle involvement, extracapital extension, positive margins. Lupron monotherapy for 7 months. And then in May 99 and going up here, in June 01, he put himself on PC-SPES. In October 01, with a PSA 3.63, he was started on hormone blockade at Mount St. Elsewhere, a well-known institution. Hormone blockade was again stopped. Then he went on Prostasol on his own. In June 04, he saw me for the first time. I treated him with a 3-pronged approach, 9 months alternative hormone blockade, 15 doses TEC. We stopped hormone blockade, continued cocktail, started cycle number 1 of testosterone. And obviously felt everything was better, looked nice. We added in some local radiation therapy for an anastomotic recurrence that existed. Then PSA dropped to unmeasurable again, and July 08, testosterone 3200 unmeasurable PSA. You know, PSA is not bad, but he had actually been on another cycle of hormone blockade, which we stopped in December 07. We started cycle 2 of testosterone. Now, notice what is happening to his PSA. Less than 0.01, 0.02, 0.037, 0.04, 0.57, 0.13, 0.15. No relationship to testosterone. I started him on a new medicine that, to the best of my knowledge, has never been used before in this type of setting. That's April 10th. Testosterone 1500, PSA almost dropped in half in 2 weeks. April 28th, 0.06, May 5th, 0.05. Testosterone 1300. Anyone want to hazard a guess what could do that? Testosterone be that high and if PSA drops immediately? I'll show it to you a little later on. We have another patient. This is a, people ask, what if I've already been treated with some of your medicines in that 3-pronged approach? I'm not going to respond, right? Remember, my daughter was about 6 years old when she said, "Ding dong, you're wrong." So anyway, so this is a guy who comes out from Illinois, 58 years old, PSA was 80, multiple bone mets, Gleason 9, high alkaline phosphatase, cycle 1 hormone blockade, 1 Casadexolone for 6 weeks. Great regimen. In December, Lupron plus Zometa. His lowest PSA was 2.97. 7 months later, PSA 26, alk phos twice normal. He was started on Taxotere, 75 milligrams per meter squared every 3 weeks, and daily prednisone. Standard, this is the FDA-approved way to give Taxotere. And as you know, if you do that compared to placebo or mitoxantrone, you can prolong life by 1.9 months in one study and 2.3 months in another. All right. But prior to that, no chemotherapy had ever been shown to prolong life in men with metastatic prostate cancer. Well, his lowest PSA was 9.38, November 07. And this is supposed to be December 07, but Joanna was just checking to make sure we'd catch it. He got his 10th and final dose of Taxotere. So 10th dose means total of 750 milligrams per meter squared of Taxotere, 75 at a time. So it's over 1,500 milligrams. So I have a patient that's castrate resistant, and his PSA is now risen 9 to 16. When I did a rectal exam, he had disease going to the pelvic sidewall. Not a pleasant picture. Started my three-pronged approach in March 08. By April, 2.67. In May, 0.99. In July, 0.425. We stopped his chemotherapy in September. In December, 0.21. I added in another thing that I'd come up with, Circadian modified 24-hour infusion 5-FU leucovorin. What is this? Well, we have chemotherapy pumps that administer 2/3 of the dose between the hours of, let's say, 8 p.m. and 4 a.m. or 10 p.m. and 6 a.m. And then the pump automatically adjusts its rate to a much slower keep open rate, and you get 1/3 the dose in the next 16 hours. When it's giving the highest dose is when your normal cells are resting. So they will not pick up the chemotherapy and cause side effect. Cancer cells, just grow whenever they want. And we also added in some Avastin. April 1709, 0.055. Guy had 750 milligrams per meter squared of Taxotere before seeing me a year ago. Pretty nice. This is a sad case. The guy was just 46 years old, February 95. And had a radical prostatectomy, PSA less than 0.5. He was a Kaiser patient in the Pacific Northwest. They said that's as low as their PSAs go. Close enough, right? PSAs start rising. In November 97, he gets radiation therapy. PSA only goes to 0.6. In July, he gets a second cycle of hormone blockade because he got Lupron for 3 months there. This is for 12 months. There's that great PSA less than 0.5. In August, starts rising, and they start cycle 3 hormone blockade with a PSA 1.5. You can't cure this guy. I mean, he's already progressed. He has had surgery, he's had radiation, he's had 2 cycles of hormone blockade. Wouldn't he be a great candidate for anti-angiogenic cocktail? Not a Kaiser. 7 months later, PSA 16. And he has castrate-resistant prostate cancer in November. They finally stopped his Casodex. By July 03, he had a big pelvic sidewall mass, lymph nodes. So PSA 15, started on Provenge. Then he developed Mets to the right femur. Met increased, got radiation therapy. Left pelvic sidewall met, increased, got radiation therapy. April '05, Mets to his upper cervical spine, 2 growing Mets in the right mid-femur and in his left temple. Increased pain in the right hip, needed a cane to walk. MRI, Mets at C6, engulfing the nerve root, right upper extremity numbness, weakness, neck pain. MRI, 4 or 5 Mets in the right femur, PSA 27. He'd been on hormone blockade for 5 years almost. Radiation therapy to the cervical spine, and some brilliant creative doctor added 1 Casodex per day. He already has, he had rising PSA when on Casodex. It's contraindicated to give him more Casodex. Because I described this as the Benedict-Arnold syndrome. Casodex will now be stimulating prostate cancer to grow. He saw me April 18th, PSA 29. I started him on three-pronged approach. Within 2 months, PSA 0.928, he had no pain. And when he saw me, he had a lot of disuse of his right upper extremity, from the Mets to cervical spine. In August '06, the MRI cervical spine showed that the mass was gone. PSA 0.16 in November, 0.05, February 0.02, stop hormone blockade, continue cocktail, and do the unimaginable, add high-dose testosterone. He's had radiation to his cervical spine, his prostate, his pelvic sidewall, his femur. And what's going to happen? PSA 1,200, I mean testosterone 1,200, 1,300, 1,500, 3,000. And as his testosterone level rose, PSA declined. Who would imagine that? Isn't that nice? And this is miraculous. And that May '07, testosterones, look at his PSA. Testosterones. Now, along in here, he developed an infection, and he has not been able to take full doses of his anti-angiogenic cocktail. And I'm going to start him on that miracle medicine we'll talk about a little while. And then how about a PSA of 842, March '04, Gleason 9. Bone scan showed Mets in all kinds of places. And he had a 6.3 by 4.2 by 6 centimeter mass adjacent to his spine that destroyed 2 of his vertebrae. In addition, there was a mass behind, abutting the rectum, that caused severe narrowing of the rectum, so that when I tried to do a rectal, my finger was displaced and I couldn't get around the mass. He had severe intractable pain, 15-pound weight loss, started him on a three-pronged approach. Just 3 weeks later, the mass shrunk from 6.3 by 4.2 to 4.6 by 2.6. And this is without radiation therapy. But I added in radiation because I don't like anything pushing on the spine. PSA, 15 doses TEC, PSA unmeasurable, stopped hormone blockade in May '05, continued some cocktail. There's his most recent PSA, April 8th, '09. This is a guy who came to me from Canada. He had a radical prostatectomy up here. His PSA 0 for 6 months. Then look what it did. In September '06, he had Mets. February '07, PSA 99. April 153. June '07, 490. we started on hormone blockade in Canada using Casodex, 50 milligrams once a day. That's innovative and stretching your neck way out. In August, 2 months later, his PSA was 231. That was as low as it was going to go. So in December, with a PSA 374, they stopped Casodex and they started Zoladex monotherapy. Now, bone scan was markedly worse. He saw me in May '08, and his doctor in Canada said, "You're crazy. What are you going to Los Angeles for? There's nothing you're going to find out there. There's no miracles, you know, and you're wasting your time and your money, and you'll be sorry." Well, first day I met him, he just told me that he'd been having intractable bone pain for more than a year. And left shoulder pain had markedly worsened in the last month. So we started him on a three-pronged approach, May 13th, '08, pain-free in less than a week. And he said, "Dr. Bob, I don't understand. How can they tell you there's nothing more we can do in Canada? And in less than a week, I'm pain-free. Why would they say that?" And one of the comments that I hear quite frequently is, if it works this well, why doesn't everyone recommend it? But they've been saying that to me and about me for as long as I've been, not quite as long as I've been a doctor, but shortly thereafter. Now, his PSA gets down to 0.8 in March '09. But by the way, how many people would like to trade healthcare systems with the Canadians for, you know, like prescription coverage or you know, the scans and all that? Turns out they don't get prescription coverage in Canada. You need medicines, got to pay. And if he wants to be treated with Taxotere, MCID, carboplatinum, well, I'll give you some Taxotere once every 3 weeks. Low molecular weight heparin blood thinner, not unless you get a blood clot. There's more than a 25% risk of blood clots when you're on Taxotere MCID. Doctor says, you get that clot and then we'll probably be able to prescribe it. Now, problems for this patient is that they're not wealthy at all. We wanted to treat him with Avastin up front. He was only able to get half-dose leukine or less, in spite of the fact that we provided him with a ton of free leukine. If he lived in the US, we could have gotten free thalidomide Revlimid for him, patient assistance. That's not available when you live in Canada. Thalidomide was never approved in Canada because of the Thalidomide Victims Association. And the worst problem that we deal with in him is the Canadian healthcare system. So in spite of a phenomenal response, it's going to be limited because we don't have access to all of the three-pronged approach. This is a fun one. This is another Kaiser patient from the Bay Area, 51, Gleason 8, had seed implants, and following that, PSA nadir to 2.1, then rose to 26 in April '06. Had a Combidex study. Are you guys familiar with the Combidex study that's done in Amsterdam? It's an MRI with magnetic particles, and they were able to identify multiple metastatic lymph nodes in his abdomen and pelvis, even though they're normal size. Like MRI or CT scans arbitrarily say if it's less than 10 millimeters, it's normal. Over 10 millimeters, it may have mets. Well, his average nodes were 7 millimeters, but they had filling defects showing that they were cancer. So he saw me for the first time October '06, PSA 43. his PAP 10.3. So the PAP elevated out of proportion. PSA always indicates aggressive disease, at least occult mets, but he had more than occult because he had all these lymph nodes. We started him on therapy, and in 1 month, 1.32, the next month, 0.569, finishes his chemotherapy in March, 0.019, July, 0.009, September, unmeasurable. We stopped hormone blockade in November '07 and put him on high-dose testosterone. Now, look at his PSA in just 3 months. I didn't like that. Going up too fast. So I added in a new medication, same one I added on this other guy. And that was April 25th. 3.3, and 6 days later, 2.02. 8 days later, less than 1. August, 0.7, 0.8. In March '09, 0.44 with a testosterone 3,700. Nice day's work. In May 13th, 0.36. That'll be his lowest. Testosterone 3,400. Duke bond study, April 30th, '09. One thing shrunk from 10 by 8 to 8.5, other from 15 by 10 to 10 by 7. No increased blood flow. What is the name of that miracle medicine? When my first practice after I left Harvard, I was in Fresno, and I saw a patient, a wonderful lady, that had a lump in her breast, and the surgeon said, you know, we're just going to cut out the lump. You know, at your age, you'll never have a problem with breast cancer. She was like 83 or 85. She saw me when she was 101. She couldn't breathe. She knew that she was sick because she no longer could vacuum or carry her garbage out to the alley. She used to go to Marie Callender's on Tuesdays with the girls, except it wasn't the original group of girls, it was their daughters. So at the time I put her on progesterone agent, Megace, and she came back to see me. What was the name of that miracle medicine that you gave me? I can breathe normally. So it made me think of miracle medicine. But there it is, ethinyl estradiol, milligram per day. And you're saying, well, wait a minute. You put him on hormone blockade? Well, what will a milligram of estrogen do to his testosterone level when he's on high-dose TRT? You guys know how the testosterone's administered? Fred? I'm sorry? No injections. It's a gel. Gel you rub on your arms every morning and stomach. So if you take estrogen, how can it lower that testosterone level? See, the effect of estrogen normally is to suppress gonadotropins, testosterone production from the testicles. But some of us believe that estrogen has a second mechanism of benefit, estrogen. It can induce castration, gonadotropin effect, but it also has a direct cytotoxic effect. It can directly kill prostate cancer cells and cause apoptosis of prostate cancer cells. And this was written about in 1996. And I was far enough behind in my journal reading that I just happened to catch that article. So direct cytotoxic effects of estrogen are independent of estrogen receptors and involves the promotion of cell cycle arrest, apoptosis, which is programmed cell death. We've treated about 11 guys who are on high-dose testosterone with PSAs that were rising too much. We added in a milligram of EE, ethinyl estradiol, and 11 out of 11 have declines in PSA, and virtually always within the first week. Now, anti-angiogenic cocktail, leukocyte Revlimid thalidomide. They're not chemotherapy, not hormone blockade, and they enhance your immune system. Isn't that exactly what every guy with prostate cancer wants? Give me something that's not hormone blockade, it's not chemotherapy, and it's going to stimulate my immune system. That's what this stuff does. And if these medicines control your PSA, you don't have to go back on hormone blockade. In my very strong opinion, your lifespan does not become threatened unless or until you develop castrate-resistant prostate cancer, rising PSA on hormone blockade. So if we can find ways to postpone or prevent the need to go back on hormone blockade, then our treatments are prolonging your life. Every month that a patient with metastatic prostate cancer is on hormone blockade brings him 1 month closer to castrate-refractory or resistant prostate cancer, and thus shortens his lifespan. Every month that a patient with metastatic prostate cancer survives with a normal to high testosterone level is just an extra month of excellent quality of life. He's not using up any of his credits. And you cannot develop castrate-resistant prostate cancer unless someone puts you back on hormone blockade, because the definition is rising PSA when you're on hormone blockade. So the key to surviving prostate cancer is 1 cycle hormone blockade, and then do everything possible to avoid going back on hormone blockade. And if you have to go on a 2nd cycle, do everything possible to make sure it's your last cycle. The longer that you are off hormone blockade, the much longer you'll live. This is my opinion. I made this up, but I'm certain of it. All right, so what about this anti-angiogenic cocktail? Could that possibly work? So here's a gentleman who was 67 in May of '97, baseline PSA 22, Gleason 6. They only did 4-core biopsy, 1 cycle triple hormone blockade. Brief testosterone. In July '04, PSA was 15, so we stopped testosterone in August '04. Now, one of the things that I've noted, commented upon, is that when you stop high-dose testosterone, PSAs fall dramatically and rapidly. We'll have better examples of it. But in less than a month, he dropped from 15 to 6.59, even though he still had a good testosterone. Okay? PSA 4 to 5, but then he kind of leveled off. Throughout 2007, the PSA was usually 8 plus. 2008, PSA rose to double digits. So most everyone I know put him on hormone blockade because he's on Proscar, so he's got to double that PSA. 10 to 12 doubled, 20 to 24, that's back to where he was in '97. Instead, put him on anti-angiogenic cocktail. And he starts that April 25th. 3 days later, PSA drops from 12.3 to 9.4. 2 weeks later to 7.38. 18 days later, 6. Another 2 weeks, 5. Another 2 weeks, 4. 2 months later, less than 2. In October '08, 1.27. In April '09, 1.18. No hormone blockade, no chemotherapy. PSA drops from 12. Testosterone stays stable. April to April, 1 year, PSA drops 92%. This is a unique case. December '95, he's 52, Gleason 6, low PSA. For 5 months, he was on 2-drug hormone blockade at Mount St. Elsewhere, 9 months of triple blockade, then Proscar maintenance. In July '03, he wanted to go on high-dose testosterone, and later I had to add in some anti-angiogenic cocktail. Okay? Let's see what happens. Starts in July '03. PSA is kind of high, but his PSA actually baseline was 6 or 7 or 8. Testosterone 3600, PSA 7, 8, 8, 7, 7, 6, 7. September '03, June '05. It's almost 2 years later. August '05, 11s. March '06, 2700 testosterone, PSA drops to 6.9. And April '06, 2100, less than 8. May '06, June '06, 1800, and the PSA is now the lowest it's been since these two numbers. Well, in June '06, he and his sister were going out for lunch one weekend, and he was found dead in his apartment. I called the pathologist and said, I want to get an autopsy. Got permission, obviously. Actually, we dug up the corpse one night, but we got permission for the autopsy. And told the pathologist, I said, here's a guy that never had local therapy. PSA is still pretty high. And I would like to have you discover where his metastases are. Said I would like for you to take his prostate gland and do stepped serial sectioning, like 1 or 2 millimeter sections, and check lymph nodes and check bones. And what he did is he sliced the spinal cord longitudinally so that he could check the entire spine. Okay? And what this says here on his autopsy report, in this case, he had 90 and 85% narrowing of the right and left coronary artery, resulting in greatly reduced oxygenated blood flow to the heart muscle, and it's had hypertension. So this is the cause of sudden, irreversible, fatal cardiac rhythm disturbance or heart attack. Okay? He was diagnosed with prostate cancer in '96, actually it was '95. He's been under treatment since that time. We only had 1 cycle of hormone blockade. At autopsy, there is no evidence of recurrent or residual prostate cancer. How many people have been told, and we're certain, you cannot cure prostate cancer with hormone blockade? It is used only for advanced metastatic disease. It can work for a few months, maybe a few years. Don't tell me that you can cure prostate cancer with hormone blockade. No evidence of recurrent or residual tumor. Prostate gland demonstrates only benign tissue. No evidence of malignancy. Isn't that interesting? Okay. Now, how about information about high-dose testosterone replacement therapy? My target range is 1,800 to 3,000. Normal 300 to 800. In the lab, low levels of testosterone stimulate prostate cancer cells to grow, while high levels in a dose-dependent fashion inhibit the growth. There's actually a bell-shaped growth curve. Low levels stimulate cancer cells to grow, then you get high levels and it inhibits. This is a physician who, at age 59, 20 years or so ago, had a PSA 134, Gleason 7. He took Lupron and I thought it was ketoconazole, not lilutamide. Had a radical. PSA began to rise 2 years later. He saw me in May of '99 for the first time. That's 10 years ago. His PSA was 12, testosterone 228. He had remarried a beautiful young lady, did not want to go on hormone blockade. did not want to go on chemotherapy. And it reminds me that a number of, it comes up pretty often, patients will tell me, you know, I would really like for you to control my prostate cancer. And if you can do it without medicines, I would really be grateful. Talk to the Lord again. So I just treated him. I added in some thalidomide. And this is May 99. This is 6 months later, 4.35. People say, there's no evidence that thalidomide helps prostate cancer. I get that from doctors all over the country. And October 2000, year and a half, 4.43, I actually wrote up his report, case report, in another patient's response to thalidomide. Okay. And in approximately June 02, he went on high-dose testosterone. This is his testosterone level. But you know, I was very conservative initially with testosterone levels. Joe, you might like these levels in the 200s and you know, 6 or 7, and whoop, too high, drop it. But we dropped the testosterone level, PSA went up. PSA 15, raised the testosterone, PSA going down. Here's again, these are PSA levels. Notice that testosterone's of 2400, 2300, didn't raise his PSA. This is when I was just learning about this stuff. And Joanna's sister is my physician assistant, Mary. And we were just dumbfounded because, like everyone else, we figured, well, maybe you're going to get away with a little bit of extra testosterone, but you get these big spikes, PSA is going to explode. Thank God, no. Okay, now we're in February 04, and his PSA was 14. It used to be 12 in 99. Then in 04 and in 05, PSA got up to almost 20. Added in some leucine, okay? And PSA, a little bit lower maybe. Cytoxin and Celebrex restart. PSA 08, 11, 11, 14, 12, 11, 10.8 with the testosterone 1200. That's his lowest PSA in like forever. Okay, that's April 09. That's now. Been 20 years since he presented with a 134 PSA. PSA rose a year and a half after radical prostatectomy. I've been taking care of him 10 years. His PSA in May 99, 11.99 with a testosterone 228. 10 years later, 10.8 and 1238. He's never been on hormone blockade or chemotherapy in the 10 years I've been taking care of him. He's been on testosterone for about 7 years and continues to work, okay? This is not me. 47-year-old gentleman, 10 years ago, he would be considered high-risk disease, 3 out of 6 cores, 1 cycle triple hormone blockade. In November 02, started testosterone, and PSAs in the 03s, 05, 06, 07, 08, 5, November 08, January 09, okay? As of May 09, it's 9.5 years since he presented with high-risk disease, 1 cycle, 13 months triple hormone blockade, followed by Proscar. He's been on high-dose testosterone for 6.5 years without anti-angiogenic cocktail. It's rare. Most everyone requires cocktail, okay? This is a patient, remarkable. February 98, he's 54, PSA just under 700. Gleason 8, multiple bone mets, generalized adenopathy, no swollen glands. He's started on hormone blockade, sees me a month or 2 later. I added in tech, not cocktail yet because I hadn't invented it yet, if you will. Overall, since February 98, 9 cycles of hormone blockade, 5 cycles of chemotherapy. Last time it was completed was September 07. 7 cycles of testosterone replacement therapy. 7 different cycles. Someone had asked, you know, like, can you use testosterone more than once? In December 08, PSA 0.09. And note, he's never had castrate-resistant prostate cancer, even after 11 years, in spite of this presentation. There are those of us who believe that when you go on high-dose testosterone, it preferentially stimulates hormone-sensitive cells to regrow at the expense of hormone-resistant cells. Because how many guys do you know that could have metastatic disease for 11 plus years, 9 cycles of blockade, and not show up with resistant disease? And April 28th, we stopped a 7 cycle of testosterone. 1 week later, PSA had dropped by over 50%. Remember, the PSAs drop rapidly and dramatically, okay? It's the rule, not the exception, that when high-dose testosterone stop, PSAs fall rapidly and dramatically. Almost all of our TRT patients are kept on maintenance LHRH agonist because they're getting testosterone through their skin. But let's say they had a rising PSA and you had to start Lupron. Well, paradoxically, the testosterone level is going to go up before it comes down. So this is why we kept men on maintenance. Now with the FDA approval of Degarolex, which lowers testosterone, in days, we may rethink. And when testosterone is stopped, the vast majority of, well, a majority of men are started on hormone blockade, but only rarely do we also have to start chemotherapy. All but a few patients are on maintenance cocktail while on testosterone and continue on cocktail after testosterone. This is a retired pathologist, 69 years old. PSA was 4, but he was on Proscar. You have to at least double it. Father, prostate cancer, age 70, died of Mets a few years later. 1 brother, 66, prostate cancer, radical prostatectomy, died of Mets 2 years later. 2 paternal uncles, prostate cancer, 1 died from Mets. Not a good family history. So we started him I started him on triple blockade for 13 months. When he went off blockade, July 99, PSAs went up too quickly. And by February 03, PSA was 7.14. We had his original path slides reviewed at Johns Hopkins. Dr. Epstein said, I can't tell that he's got prostate cancer. However, PSA is now 7, and in spite of Proscar. So we biopsied him, and he was a Gleason 8. Started cycle 2 hormone blockades. This was Dr. Tucker, and he used 13 doses of TEC. Stopped his hormone blockade May 04 with this PSA. He reconsulted with me December 05. PSA was back up to 9.28. This is terrible. 2 cycles hormone blockade, 1 cycle chemotherapy, and he needs to be retreated. So what do? Anti-angiogenic cocktail. Not hormone blockade, not chemotherapy, stimulates the immune system. PSA was 9, immediately drops to 3.49. In February 06, he had stopped his thalidomide. Put him back on it, 3.6, 2.39, 1.79, 1.46, October 06. Gets down to 1.15 in April 07. Unfortunately, some compliance problems. He doesn't like taking his medicines. And when he doesn't take his medicines, PSA goes from here to here to here. Took medicines, stopped medicines, restarted, gets down to 1.52 January '09. And he presented in me 98 with unknown Gleason score because Epstein couldn't confirm prostate cancer. March '03, Gleason 8, PSA 12. December '05, 9.28, and all he's been on is cocktail for 3.5 years. And PSA 1.93, and T150. Total survival, 11 years, no castrate-resistant prostate cancer. So he's outlived his entire family of members with prostate cancer. What are the benefits? What do guys tell us when they're on testosterone? I feel better, I feel stronger, improved libido. I think I went over this before. Depression is gone or improved, fatigue is gone, more motivated, morning and or nocturnal erections, fat turns into muscle, although it does require exercise, and improved mental acuity. Guys have told me that their memory's better, concentration's better, they could work crossword puzzles again, which they had missed, they could play bridge and actually help to win, they could handle complex tasks at work. Who made that up? That was a direct quote from somebody here. Anyway, here's another thing, that if you've never been in this situation, guys tell me that they have increased body hair, especially on their arms, legs, and chest, which makes them feel more masculine and restores positive self-image. Isn't that interesting? I mean, I wouldn't have thought of that. You don't have hair on your chest or on your arms or legs. I didn't know that it would, cause distress to a lot of guys. So, what else? They treats osteoporosis, raises red cell counts, and probably improves cardiovascular risk factors. Okay? In terms of side effects, some wives have told me, I think you're giving him too much. I usually recommend that they buy their wife a new pair of tennis shoes. Now, in terms of thinking about testosterone, when failure is manifest under estrogen suppression, in other words, you're taking estrogen, it's suppressing prostate cancer, reversal to the opposite extreme of androgen-estrogen balance should be instituted, and observation of its effect recorded. When was this article published? A couple years ago, 1947. 3 patients with advanced prostate cancer, prognosis was regarded as hopeless. Now, there's a nice term, isn't it? Doc, how am I going to do? Hopeless. I mean, give them some hope. Tell them, I once saw a patient, lived 3 weeks. Give some hope, something. Anyway, of these hopeless patients, 2 of the 3 symptomatically improved on testosterone. And within 2 weeks of starting it, 1 had an absolute reduction in size of the prostate. Improvement lasted 5 months, at which time the symptoms recurred, so he was giving another cycle of testosterone, and again improved. They wrote in 1950, seems to us that if continued progress is to be made in treating prostate cancer, the exact role of androgens in the induction of cancer and or the maintenance of cancer growth must be ascertained. In other words, we don't really know. It'd be nice if we could find out. 1950. So that's what, 59 years ago. Another patient, 76, severe back pain, weakness, weight was down to 89 pounds. He, 5 years before that, had orchiectomy plus estrogen. He could not sit without assistance, appeared terminal, extensive bone mets, PAP 50 times normal. So they started him on testosterone. 1 month later, pain-free. Appetite became excellent. Weight rose to 112. This dropped 75%. Later gained 30 pounds. remained on testosterone for about a year. Testosterone alone may therefore be indicated in cases of relapsing metastatic prostate cancer which were unresponsive to estrogen. Case report 1971. I mentioned alternative hormone blockade. How would you treat metastatic castrate-resistant prostate cancer? Well, most experts use sequential endocrine therapies. If someone is on Lupron and Casodex, they stop Casodex, wait a month to see if your PSA goes down, androgen withdrawal syndrome. If it doesn't, then they'll prescribe flutamide. If that doesn't work, they'll prescribe nilutamide. If that doesn't work, or if it does and then progresses, they'll add estrogen or ketoconazole, one after the other. Or they'll add high-dose Casodex. And when I was a Casodex investigator, if someone progressed on 1 a day, about 30% of the time, they responded to 3 or 4 a day. So there are numerous secondary hormone blockade options. Unfortunately, none has ever been found to prolong life. The average response rate, 35%. Average duration of response is only 3 or 4 months. Problem of why I never prescribe an anti-androgen a second time. Initially, anti-androgens, Casodex, flutamide, etc., is like a key in a lock. This is the hormone receptor. The Casodex is the key, goes into the lock, turns the lock to the right. That causes prostate cancer cell death. Now, over time, there's a mutation in the lock or some other mechanisms. And now when Casodex attaches, it turns the lock to the right, and it stimulates prostate cancer cells to grow. So I call that the Benedict Arnold syndrome. Now, in the French and Indian War, Benedict Arnold was a great general for the US. Many victories. But in the Revolutionary War, he turned traitor, didn't become neutral, turned traitor and really hurt us. Now, I mentioned that we see a lot of patients from out of the country. Not one European person, a patient I've ever seen, knows anything about Benedict Arnold, whether they're from London, they're from England, anywhere. So this is definitely just an American concept. Now, I don't know how it was with you guys in school, but it seemed everyone knew who Benedict Arnold was. So this kind of explains what I just mentioned, okay? So I do not use these more than once because I mentioned that with mutations, these can stimulate prostate cancer cells to grow, okay? Or you could say, well, let's start them, and if I see the PSA go up, then we'll stop them. But what if they're on a three-pronged approach? Chemotherapy is going to lower their PSA. The cocktail is going to lower their PSA. You won't be able to recognize that the anti-androgen is raising their PSA. That's why I only use them once. And that means if they progressed on Casodex, I don't use flutamide or nilutamide, or even high-dose Casodex. Additionally, what you're doing with all those sequential hormone blockades is you're saying, I recognize that only a smaller and smaller percentage of the cells are going to be hormone sensitive, but some of them still are. I'm satisfied to kill some of them. The major enemy is not the hormone sensitive cells. You can get those suckers anytime. It's the hormone refractory ones. And that's what you need the chemotherapy and the cocktail for. Now, if your PSA ever rises while you're on an anti-androgen and you have castrate level of testosterone, it is contraindicated to ever take them again. Because what will happen if you do? Well, I'm saying somebody was already on Lupron and Casodex, PSA initially dropped, but then rose. You take them off Casodex, and 3 or 4 years later, they say, initially I was on Casodex for 4 or 5 years. I did great. Why don't we try it again? I haven't had it for 4 years. Because if you do retry it, that medicine will stimulate prostate cancer cells to grow. The body never forgets. That's why it's contraindicated. People who want to argue with that, remember, everyone is entitled to their own opinion, their own wrong opinion. I've been saying that now for about 16 years. This is just a pearl. Infections anywhere in the body, I've observed, can raise PSA, not just in the prostate. I've had guys with septic joints, PSAs are up, joint gets strained, PSA drops. Now, everyone is interested in participating in their health and trying to help control their prostate cancer. And we've all tried selenium and vitamin E and resveratrol and pomegranates and curcumin and shark cartilage. Fred, there's 25 different things we've tried. Well, there's no prostate cancer benefit from selenium, vitamin E, resveratrol. None. What seems to be probably beneficial, specifically cruciferous vegetables, broccoli, cauliflower. 2 servings of tomato sauce per week, no evidence Lycomato does any good. 2 servings of fish, but not tilapia, which is very high in omega-6. 5 servings per day of fresh fruits and vegetables. Using a Mediterranean diet doesn't help prostate cancer, but it's the healthiest for you. And of course, exercise. Here's a study that was just published in November 08, 1,200 men age 60, baseline PSA 1.9. They had LDL cholesterols of 144. They were put on a statin. For every 10% decrease in LDL after starting a statin, would their PSAs drop 2 to 5%, 6 to 14, 15 to 24? How much do you think their PSAs would drop, if any? The answer might be none of the above. None of the above. It won't drop at all, right? Let's see. 17%, you're right. PSA dropped 17% when you went on a statin and when your LDL cholesterol went down. Isn't that interesting? Now, there's 2 major forms of cholesterol, HDL and LDL. Which is the good cholesterol, which is the bad? The what? HDL is good. How many did not know that? Or were not 100% sure that's correct? HDL begins with an H. You want it to be high. Higher the better. Higher your HDL, lower your risk for having heart attacks or strokes. Nice, easy way. LDL begins with an L. And a lot of labs still claim that 130 on the LDL is normal. Most doctors will recommend less than 100. If a patient has had a prior cardiovascular event, then the ideal level is 60 to 70. Why wait for your first heart attack or stroke to get your LDL down to 60 or 70? Recently, like in the last week or two, Crestor, 20 milligrams per day, published an article that not only did it reduce the risk of heart attacks, strokes, and all that stuff, it lowered the risk of forming blood clots in the veins by 25%. And when guys are on chemotherapy, Taxotere, 25% risk of blood clots, we use anticoagulants, but they should also use a Crestor. Now, is the effect of lowering PSAs because of a cholesterol effect? The answer is statins appear to significantly decrease the risk for developing metastatic prostate cancer and also of dying from prostate cancer. Statins reduce the number of inflammatory cells found around the prostate epithelial cells, and reducing inflammation seems to be beneficial in reducing the risks for developing many types of cancers. So the statin effects go far beyond the lowering of the cholesterol level. Statins inhibit inflammation, cell proliferation, angiogenesis, migration, adhesion, invasion, other survival signals. At a very recent FDA investigators meeting, attendees were asked how many were personally taking a statin, even with a normal cholesterol level. 100%, and have been for years. I would like to thank Joanna, just went outside, my office administrator and friend for making today's slides possible, Mary Duong, my PA, for helping me take care of our patients and helping out in the presentation. Their assistance and support made it possible for me to overwhelm you with all of this today. And as always, be happy, be well, live long and prosper.
If a person's on triple hormone blockade, what criteria do you use that he needs further treatment?
The first thing is the only time that I recommend triple blockade as the only therapy is men who present with previously untreated low or intermediate risk prostate cancer. No prior local therapy, no prior hormone blockade. And if you have had either of those, then you need more than triple blockade. And like, how high was your PSA when you got started?
14, now it's 101, but I'm wondering when I use that additional treatment.
Right. Did you have any prior local or systemic treatment?
I saw you in 1998, and I had treatment in 2007.
So you had no treatment from 98 to 2007?
And the PSA rose, but in the spring of 2007, it shot from 9 to 14.
Interesting, because there's a study they did, men who were on active surveillance, PSA is under 10, where part of the protocol was that following a positive biopsy, they had repeat biopsies done. And of course, were followed with PSAs and everything. 55% of the men whose repeat biopsy also showed prostate cancer had PSAs drop. So there's great PSA fluctuations in men with a prostate. And when, you know, every man believes that their PSA soared from, 1 to 1.9, 9 to 14, 2200 to 3300. Everything is relative. Yes.
Thanks a lot for your information. I really enjoyed it very much.
Welcome.
I wanted to see what is your idea about Provenge.
Yeah. Well, I've never been a Provenge fan. And the study that they just reported out Do you remember what the average PSA decline was on Provenge? Because there wasn't any. And the protocol was not Provenge versus chemotherapy. It was initial chemotherapy followed by Provenge versus Provenge followed by chemotherapy. There are a lot of people who have difficulty believing that this product is going to actually be approved. I don't know enough about it, but you know, the product went up so many times before the FDA, and they never met their end result that, you know, their primary point of improved survival before. And now the improved survival they report is difficult to comprehend when PSAs didn't decline.
Doctor, what % of your patients with advanced disease do not respond to the three-pronged approach?
I'm glad you asked. Nathan?
In my statistical work, I haven't found any man yet who did not respond to the three-pronged approach.
It's, I tell that to new patients. I said, I'll tell them that our response rate is just about 100% when it's been 100%, but you can't say it's 100%. And every single guy who came to us with pain on narcotics was pain-free usually within 1 or 2 weeks. And I mentioned that when I told Nathan that I know our results are better than anyone's in the world, I know he kind of looked at me a little askance and with a jaundiced eye, but what have you found?
We have about 180 men with 7 years of follow-up. And we have, of the men who stayed in the program and got the three-pronged approach, we've had 6 of those 180 men who died of prostate cancer after 7 years. Better than 95% survival at 7 years. And I've extensively looked on the internet at a website called PubMed. PubMed is sort of the place where the federal government puts all the good studies. And it's a place to look if you want to know the inside of all these studies, PubMed. And in that research on PubMed, I've not found any reported results that have as high survival for men with high-risk disease. So it's, in my view, it's really powerful.
Dr. Bob, could you talk a little bit about your philosophy of using your own research versus academic research to base your decisions on?
Yes, I have perhaps benefit, you know, having done my fellowship at Harvard. I got to look down my nose at everyone else, and I know that we thought at the time that the medicine stopped being handled at all west of the Mohawk or something. I remember in my hematology fellowship that like when we had patients with acute leukemia, they're really sick. And summertime in Boston, they were treated on a ward, you know, haul in, and then all of these beds, a semicircle, separated by curtains, no air conditioning, windows are open, flies going in and out. And they had just completed another research building that was 12, 15 stories high, air conditioned, all new labs. Seemed like the emphasis was on the wrong place. And I've always been a very strong patient care advocate. And what that meant to me is that I have difficulty with prospectively randomized double-blind studies comparing treatment aid to placebo. because half your patients are going to get randomized to placebo. I've always believed that, and I've always done it this way, is that I'll evaluate the disease, the condition. I'll decide what I believe the evidence suggests is the most effective therapy today. And then I'll use it. And if there isn't any known, I will try to fill the void. And having been trained as a hematologist-oncologist, it allowed me and continues to allow me to apply knowledge gained from treating other malignancies to prostate cancer. For example, the first disease that I treated with taxotere carboplatinum was metastatic lung cancer. So additionally, when you're treating people by protocol, you're obligated to follow those rules. Like Abiraterone, a patient must be off all other medicines for 1 month. And you can't add in cocktail if they're on Abiraterone. And I understand the necessity for that, because a good scientist, as I quoted Mr. Spock, is the good of the many outweigh the needs of the one. It's a tough one, but my feelings are for each of my patients, the answer is no. The goods of each one, the needs of each single one of my patients outweigh the needs of the many.
I had a question of whether your therapy is appropriate to somebody with beginning or moderate stage prostate cancer as a primary treatment.
Well, if it's primary treatment, if they have low or intermediate risk disease, they only need 13 months triple hormone blockade. And you can look up on my website, which you can take a card, it's listed here, compassionateoncology.org. And you can download any of my papers for free. Additionally, there you can call the office and you can order a DVD lecture like on management of, I think the lecture that talks about low or early disease is demise of the gold standard. Because it's really self-declared gold standard. Urologists and radiation therapists said the gold standard for treating prostate cancer is radical prostatectomy. Well, excuse me, how did you determine that? Well, we self-declared it. Therefore, that's it, that's the answer. Ding dong, you're wrong.
So this is a follow-up for the hormone blockade?
This is for men with advanced, recurrent, metastatic, hormone refractory, or high-risk disease.
That clarifies a lot for me.
Good luck.
Doctor, do you ever use an aromatase inhibitor?
Yes, they're pretty effective in treating breast cancer. The studies in prostate cancer do not show any benefit.
Not in combination with this testosterone?
I don't find that I need it because I use Proscar and Avidart to inhibit DHT production.
I saw a record you kept for a patient once. He brought it to me and showed it to me. And I thought it was fascinating. You keep really a good set of tests on every patient. I'd never seen things before, except on that piece of paper. But anyway, there was an unusual cycle where when the estrogen was up, the testosterone was down, and the PSA was up. And you reverse that, and you could see it. Every time you had that situation, you could see, I mean, you could look at the estrogen number and tell whether the testosterone or the PSA was going to be up or down. You didn't need anything else. So I just thought I'd throw it out there.
Okay,
Okay?
thank you.
I want to thank you.
Thank you.
I want to thank Dr. Liebowitz for coming out.